You sound good now.
Okay.
Yeah,
Okay.
everything's okay now.
Okay.
I'm just going to start the webinar, everybody.
Yeah. So if everyone can hear us, we are just going to give another minute or so for anyone that's a little bit late to join the webinar, and then we'll get started at 6:05.
Okay, Rohan, do you want to get us started now?
Yeah, for sure. Okay. So good evening, everyone. Thank you for joining us for today's panel discussion, A Vaccine Recovery. My name is Rohan Sharma, and along with Kira Murison and Ronaz Ramtilla, we are the co-directors of events for the Infectious Disease Working Group. I'm a first-year MPH Occupational and Environmental Health student, and Kira and Ronaz are first-year MPH Epidemiology students at the Dalla Lana School of Public Health at the University of Toronto. Ronaz, Kira, and myself will be your moderators for tonight's event. Now, I would like to share a bit of information about the Infectious Disease Working Group. At the beginning of 2020, this group was formed as a public health student-led initiative based out of the Dalla Lana School of Public Health at the University of Toronto in response to the uncertainties around COVID-19. While there was a swift response in the scientific and public health community around the world, there was also a spread of fake news and mounting barriers to accessing resources. From this uncertainty, the mission of this group became to synthesize, share, and exchange information and resources on COVID-19 to improve the health and well-being of Canadians and those affected around the world. Before we begin, I would like to take a moment to recognize the land on which the University of Toronto operates, and although we may not all be in the same place, this is where many of us are situated during tonight's panel. For thousands of years, it has been the traditional land of the Huron-Wendat and the Seneca, and most recently, the Mississaugas of the Credit River. This land is a sacred land and has been the site of human activity for at least 15,000 years. This land is in the Dish with One Spoon Wampum Belt Covenant, an agreement between Iroquois Confederacy and the Confederacy of the Ojibwe and the allied nations to share and care for the land around the Great Lakes. Today, this meeting is still home to many Indigenous people from across Turtle Island. There are a few housekeeping items we would like to go over before we begin. So tonight's session will be recorded. This recording will have captioning and will be provided after the webinar is over. As well, this is a Zoom webinar, so all participants are muted on the call. Our panelists will each have an opportunity to present, and this will be followed by a question and answer period afterwards. The chat function can be used to ask questions during the presentations, and these will be addressed in the question and answer portion of tonight's panel. Please respect the speakers and other participants in the webinar and do not screenshot or record without permission. Finally, if you need technical support during the webinar, please message me privately on Zoom. If you can select my name individually or email Rohan at the email you can see on the screen, rohan.sharma@mail.utoronto.ca. I'm going to give the spotlight over to Kiara now.
Thank you, Rohan. So one of our key values in the Infectious Disease Working Group is to be transparent about what we do and don't know. This is part of the premise for tonight's panel discussion. As we move further along with the vaccination process of people in Canada and across the world, we wanted to provide an opportunity for experts in the field to present information and answer some questions. We have a wide range of panelists this evening who we are so glad could join us. So first, I would like to introduce Dr. Byram Bridle. Dr. Bridle is an associate professor of viral immunology at the University of Guelph. His research program focuses on the development and optimization of immunization strategies to protect against infectious diseases and treat cancers. He was commissioned by the Ontario and federal governments to generate novel COVID-19 vaccines. He has made himself available to the media to provide fact-based answers to outstanding questions about COVID-19 vaccines, including in a recent interview for W5, which is linked on our Facebook event page and will be linked in the chat for anyone who would like to take a look. Next, we have Wilson Lee with us tonight. Wilson graduated in 2009 from the University of Toronto, the Leslie Dan Faculty of Pharmacy, and began his pharmacy career at Shoppers Drug Mart. Wilson became a certified diabetes educator in 2012 and subsequently the pharmacy manager in 2014. He has been invited as a speaker to numerous national conferences and published in journals sharing his innovative practices in diabetes care, point-of-care testing, infectious disease screening and prevention, and pharmacogenetic testing. In 2014, Wilson was involved in the publication of a study that served to understand patient experiences and perceptions surrounding being vaccinated by a pharmacist. We're going to link this in the chat as well. In 2016, Wilson and his team piloted a rapid influenza A and B screening program in the pharmacy to expedite patient access to care and improve clinical outcomes, which was published in the Canadian Pharmacist Journal. In recognition of Wilson's dedication and involvement, he was awarded the Shoppers Drug Mart's We Care Award in Disease Management in 2014, and was also named the Pharmacist of the Year in 2018. During the pandemic, Wilson and his team have continued to be at the front lines of his community, providing crucial patient care, vaccination services, and COVID testing. Wilson also currently practices at McKesson Specialty Prescription Services, caring for complex and special patient populations. Next, we have Jean-Paul Soucy with us tonight. Jean-Paul is a Vanier Scholar and a PhD student studying infectious disease epidemiology in the Dalla Lana School of Public Health at the University of Toronto. He is a co-founder of the COVID-19 Canada Open Data Working Group, which curates a centralized repository of COVID-19 data in Canada. He also maintains the group's dashboard and vaccine tracker. In addition to this, he co-founded the University of Toronto Journal of Public Health and serves as the journal's epidemiology editor. Finally, tonight we have Dr. Kate Mulligan as well. Dr. Mulligan is a health geographer with interests in health equity, community health, advocacy, and political ecology. She is a Status Assistant Professor in the School of Behavioral Health Sciences here at the Dalla Lana School of Public Health and the Director of Policy and Communications at the Alliance for Healthier Communities, a network of equity-focused community health organizations across Ontario. Kate sits on the Toronto Board of Health and the boards of the Association of Local Public Health Agencies and 8 to 80 cities. So I think now we are good to get started. Dr. Bridle, if you would like to get us started.
Yes, hello everybody. I'm just going to pull up my presentation. So I would like to thank these very talented trainees that have invited us to speak tonight. And I'm very excited to be here along with my fellow speakers. And I'm going to talk to you about COVID vaccines. And so what I'm going to do is my presentation is going to be kind of a, I guess, a prelude to what the end of this session will be. I'm going to go through this like a question and answer session. Okay, so I've been asked all kinds of questions about COVID-19 vaccines. And so what I've done here is I've summarize a lot of the most common ones that I've heard. They go from, you know, fairly basic questions to some very sophisticated ones dealing with some complicated immunology. All right, and the whole idea here is, well, as was mentioned, I'm a viral immunologist, first of all, and I work on developing a number of different vaccination strategies. I teach my students, I teach immunology to undergraduate students and graduate students, and I really preach the value of vaccines. They are an excellent way, the most cost-effective way to prevent disease, right? When we think of medicine, it's often treating disease after it's occurred. Vaccines are an excellent strategy for preventing disease, and it saves millions of people around the world from diseases and death each year. And but with that said, I would like to highlight outstanding questions because we're in a unique situation here with these COVID-19 vaccines. Just the fact that they've been developed and licensed so rapidly for emergency use in of itself creates some unique questions. And again, just to make sure we're on the same page, what we're talking about here is we are talking about COVID-19, which is the disease. That's the coronavirus disease that started in 2019. And this disease occurs in some people that are infected with the severe acute respiratory syndrome coronavirus 2. Or I'll just refer to that as SARS-CoV-2 from now on, okay? And so with these vaccines, we have two now, the Pfizer vaccine and the Moderna vaccine that have been approved for use, emergency use, again, in Canada. And this has definitely raised hopes across the globe, that the pandemic is therefore nearing an end. And we all hope that this is in fact true. But again, what I'm going to get to here are some outstanding questions that could be potential sticking points. And the whole point of my talk really is, I don't want anybody, if things don't go as planned, if we don't get out of this as quickly as possible, I just don't want anybody left saying, why didn't somebody tell me that this was a possibility, okay? And so I'll go over these. So one of the first questions, and probably the most common one that I've received, is what is the long-term safety of these COVID-19 vaccines? And the reality is that these COVID vaccines have received regulatory approval in record-shattering time. So I actually, early on in the pandemic, was interviewed by the media about these timelines and predicted that there's no way we would have vaccines out by this point in time. So obviously I was completely wrong. I didn't feel it was an impossibility, but a very remote one. But with that said, I do want to point out that it's actually not a fair comparison to previous vaccines, simply because previous vaccines did in fact have to go through the typical process and actually complete phase 3 studies prior to the rollout. Whereas in this case, we're dealing with vaccines that have been approved for emergency use only partway through these phase 3 studies. And in fact, a lot of the information that we would normally have for historical vaccines won't actually be available for about another 2 years. So in fact, so we have to keep that in mind. But nevertheless, we have these in record-shattering time, and this has created some unique questions, such as the question of what is the long-term safety profile. And so because these vaccines only have months worth of data rather than years, because the fastest vaccine to get through the clinical trial pipeline previously was an Ebola vaccine manufactured by Merck. And that we thought that was an astounding timeline. Then they got that through in only 4 years. Most vaccines traditionally take about 10 years, give or take 5. And so what that means is by the time these get rolled out into the public, we usually have years worth of data, that has accumulated. So what I can say with certainty is that the acute safety, right, or the short-term safety profile of these vaccines looks good. And again, but this is only because we have months worth of data, but so far so good. Of course, there have been some highlighted issues with anaphylactic reactions, and these started on the very first day of the rollout. So that, of course, hasn't helped with the optics for people who are hesitant about these vaccines. All right. And the reality is we won't know if there's any, unpredicted long-term side effects until time has gone by. And so what this means, of course, is that one potential issue with the vaccine rollout is that if there are indeed any unpredicted severe long-term side effects that occur at too high a frequency, right, this could be a reason for withdrawing approval of some of the vaccines. Now, of course, that risk is reduced by the fact that we have multiple vaccines, 2 that are available so far, and likely, several more coming out in the near future. So that helps mitigate that risk. The other question then that I've been asked, which is related, is what is the duration of immunity of COVID-19 vaccines? By the way, you'll see some of this text is in blue. The organizers of this meeting are welcome to share my presentation, and what these are, where the blue text is these are links to information that backs up these statements. So duration of immunity is essentially how long a person is protected after being vaccinated. So again, for previous vaccines, we'd be reasonably confident prior to their rollout that the immunity that those vaccines conferred would last at least a few years. And that's because they would have been in clinical trials for quite a few years. And so the issue here potentially with the COVID-19 vaccines is, again, we only have a few months worth of duration of immunity data. So for example, for Pfizer, when they first published their data, it was showing 45 days after the peak immune response, that immune response was still being maintained. They updated that a few weeks ago in the New England Journal of Medicine. They extended it to 90 days, and it still looks like the immunity is nice and high. So that's good news so far. But just keep in mind, it's just 3 months worth of data. We don't know what that curve is going to look like, right? At what point that immunity is going to start to drop off and potentially go below a protective level. And the point is this: if immunity were to decline before herd immunity is achieved, then previously vaccinated individuals, so those that are vaccinated early in the rollout, will become susceptible to infection again, right? So this means we're going to need, it's estimated that we're going to need in the ballpark of 60% or more of Canadians to become immune before this virus can stop spreading. And so what that means, it's going to take, as you can see, quite some time to reach those numbers, right? The rollout is occurring very slowly. So if it takes, so for example, let's say it took 1 year to get enough Canadians vaccinated to achieve herd immunity, but the protection conferred by the vaccine wanes too much by 6 months. This is just hypothetical. What that means is then is in the last 6 months of the rollout, the people who are vaccinated in the first 6 months are susceptible again, the virus can start recirculating, okay? And that would cause failure of the rollout. Another one that I've been asked about, especially very recently, because I had an opportunity to look at the some of the data that the FDA, United States Food and Drug Administration, looked at when they decide, and that was on the data that on which they based their decision to license the Pfizer vaccine. And so this has garnered quite a bit of attention recently. So as most of us would be aware, the public declarations of effectiveness of these vaccines is 90%. That meant that in the partially completed phase 3 trials, they had volunteers, half of which were vaccinated, half were not. And if people were in the group that got vaccinated, they acquired 95% fewer of those people, and that arm of the trial naturally acquired COVID-19. All right, so that's where they got the 95% effectiveness. If they were vaccinated, they were 95% less likely to acquire COVID-19. But it's since been found, unfortunately, this surprised a lot of people, that the level of efficacy, that's the reality. It seemed incredibly good. But unfortunately, what's come out since is that Pfizer actually did not publicly disclose the fact that they excluded a huge data set. And these were what were called suspected but unconfirmed cases of COVID-19. All right. So what we have to appreciate is this effectiveness data was based on the few people in the trial who had confirmed cases of COVID-19. That means they went for the test that we would go to at our test centers and have that nasopharyngeal swabs, which directly detects the genome of the virus. And those were the ones that the effectiveness was based on. And it turns out that there were 20 times more people with these suspected but unconfirmed cases of COVID-19. One question, of course, is why were these left unconfirmed, et cetera. But the point is, this was only revealed in a summary report that was issued by the Food and Drug Administration after they approved the vaccine. And what I want to point out is with these new data, by including these new data, a reanalysis was done by the associate editor of the British Medical Journals. And the link to that is here. And this is the key message. With their new calculations, they did it a couple ways because we don't have the raw data. So they had to make a couple of assumptions. And one was more conservative and one was more aggressive assumptions. But based on this, they've predicted that the actual effectiveness might be as low as 19 to 34%. And again, I want to point out, this can't be confirmed or refuted until the raw data are released to the scientific community. And it's already been stated that likely won't happen for approximately 2 years. But keep in mind, the cutoff for approval of the COVID-19 vaccines was set at 50% effectiveness, okay? And the point that I want to get to here is obviously, if the real efficacy of the vaccines is less than quotes advertised, right, then obviously these vaccines are going to underperform relative to our current expectations, all right? So that's another potential sticking point. Now, there's been a lot of talk recently about novel variants of the Sars coronavirus too emerging. We saw that happen in mink in Denmark, where we had human to mink to human transmission, and while in the mink, the virus mutated. There's also been ones that have been identified, highly publicized in the UK and South Africa, and this is why it occurred. So one of the things I want to point out here is that coronaviruses copy their genetic material in a way that inherently induces random mutations, okay? This allows them to adapt very rapidly to changing environments that they find themselves in. So because this is largely random, this means that the risk of emergence of mutant versions of the virus that can effectively evade vaccine-induced immunity can't be accurately quantified, okay? But what I do want to point out is that the way the COVID-19 vaccines are being rolled out is being done in a way that that could actually increase the potential for this to occur for two reasons. First, the current vaccines confer narrowly focused immunity, right? They're focusing on a single protein on the surface of the virus. This is known as the spike protein. And this means that in order to evade that immunity, they just need to be able to mutate that one single protein in order to evade the vaccine-induced immunity. So far, it doesn't look like this has happened. Although there's some questions about the with the UK variant. People are looking into it. But secondly, the vaccination program, again, is being rolled out in a piecemeal fashion, right? We've seen this, you know, a couple thousand doses in each province, right? And then spread out quite largely among individuals throughout those provinces and territories. And what this means is that we are going to, and here in Canada, we are going to have a very slow expansion of this narrowly focused immunity among people. And these people that are getting vaccinated then are going to be surrounded by a bunch of other people that are not immune, right? And what this does is this is going to provide the time and the physical, relatively close, right? We're supposed to be physical distancing, but still relatively close physical contact with a group of people that can serve as what we call a reservoir population, right? That allows this virus to circulate. And then this virus will have the time needed and the opportunity, right? The relatively close contacts to they'll have the time in this reservoir population to generate random variants, and then they'll have the time to really probe their potential to reinfect vaccinated individuals. And if a random mutant occurs that's capable of, over time, infecting somebody who's vaccinated, by definition, then that virus is no longer susceptible to the protection conferred by that vaccine, okay? So again, the way we're rolling this out, and which is out of necessity, right, will actually has a potential to promote and enhance or increase the chances of one of these variants happening. And so again, if it's altered spike protein enough, it's going to bypass these vaccines. So what I would point out, if this happens, the vaccines may actually need to be re-engineered to express the new version of the spike protein from such a mutant. And what I would recommend, certainly as an immunologist, is that we include in those vaccines, the next generation vaccines, additional proteins to broaden the immunity. And so this is kind of interesting because, in fact, the acquisition of natural immunity, in other words, if somebody's infected with the virus and they haven't been vaccinated, so they get infected and clear that virus, they're going to mount an immune response. That immune response will inherently target multiple components of the virus. So interestingly enough, those of us who do acquire natural immunity may actually be at reduced risk of reinfection with variants that have learned how to bypass that spike protein specific vaccine induced immunity. All right, and so I have additional questions, but again, I'd rather answer the questions that the group has here. So I'm going to pass it on to the next speaker. Thank you very much.
Thank you, Dr. Bridle. We have a lot of questions popping up here, so definitely a great talk. I will just remind everyone, if you could put your questions in the Q&A box, it's just easier for us to keep track of them for the end. And next, I will hand it over to Wilson.
Thank you so much, Dr. Bridle. That was a lot of good information. I'm actually going to check out that efficacy link because I've been reading the New England Journal of Medicine on their number, and I've heard of some questioning regarding whether that's a true efficacy. So that's actually very insightful to me. Thank you for that. My name is Wilson Lee. I'm the pharmacist of the group. I'm just going to share my slide quickly here. Everyone can see that? Okay, perfect. Okay, so thanks again. My name is Wilson. So as a clinical pharmacist, I do want to share my and my team's experience of what it really means and really feels to be every day at the front lines of healthcare during a pandemic, let alone the busiest flu season we've ever encountered ever, and also doing asymptomatic COVID screening on one of my other stores. And hopefully some of these lessons, best practices, challenges can be applied and carried over through the upcoming COVID vaccine that we're tasked upon onto pharmacists. We're already hearing word from the Ontario College of Pharmacists that they're in constant negotiation, discussion with Public Health and the Ministry of Health of Ontario. In terms of setting up a plan and the distribution, I just actually received a survey in my inbox, so I was seeing how ready pharmacists are and what concerns that they should be addressed before that's actually rolled out. So in terms of disclosures, I don't have any conflict of interest for this panel. I have given talks before for the following organizations related to some of my research in diabetes management, point of care testing, and pharmacogenetic screening. As you can see, there's no vaccine companies here, so that declare there's no conflict of interest for me being on this panel. Just a little bit of myself for where I'm coming from. So I'm a Leslie Dan graduate, proud Leslie Dan graduate pharmacy from U of T back in 2009. And back then going to pharmacy, I envisioned my practice to do more than just counting pills all day, like the stereotypical pharmacist. And that's not what I envisioned my career to be. And I'm glad it didn't turn out that way. And it was the perfect time to be a pharmacist. That's really, truly, when pharmacists were evolving in terms of what they're allowed to do and being tasked to do in terms of the public health demands. And frankly, we are still very short of physicians, and a lot of these tasks, pharmacists have stepped up nicely, I would say, for the past 10 years. So this is an outline from the scope of practice of pharmacists. And when I first graduated, we were allowed to do something called medication review, which is a more one-on-one in-depth consult, similar to how doctors check up on patients yearly, but we would check up in terms of a thorough consultation for medications, diabetes management, home visits, even actually do those on a weekly basis. Pre-pandemic, unfortunately, I don't get to do too many of them now. And in 2012, something unique arose, was pharmacists giving vaccines. And it really gave me a sense of what it truly means to be a clinician providing that direct patient care. And really changed my view of me being a professional. And since then, vaccines uptake has really taken off. And an independent study group called 9,000 Points of Care, 9,000 referring to the roughly 9,000 pharmacies across Canada, we can actually redivert 17 million physician visits to pharmacists because we're more than capable to take on those tasks in terms of vaccinations, providing consult, and referring and triaging appropriately. And we are actually in talks on table in terms of minor ailments. A lot of provinces, pharmacists are actually prescribing for minor ailments, infections, conditions that doesn't require a physician's visit. And during the pandemic, that really showed where pharmacists are stepping up to meet the needs of vaccinations. So with this year's flu season, as you all know, I'm sure you've seen all the headlines and pictures. So the numbers are true. It's been growing since the inception of vaccinations that pharmacists are providing. And the milestone really occurred in 2017-2018's flu season, where we actually did more flu vaccines than all physicians combined. So the ministry did recognize that. And we're more and more consulted and called upon to meet the needs of vaccinations of our local communities. And you can see how this year went. We did anticipate on a quick early uptake of flu vaccines, but it was actually more than we anticipated. So we really had to adapt on a day-to-day basis. As a pharmacy manager, I had a constant emergency call list of pharmacists and otherwise I wouldn't have been able to manage such a high volume. And in fact, we gave, as a company, 2 million flu vaccinations in as little as 5 weeks. So just to give you a sense, we gave pretty much 75% of all of last year's vaccinations in just a month and a half. So it was quite intense. And I ended up, I remember Thanksgiving holiday, I was working a 7-hour shift. I gave 100 flu shots myself, but I have really well-trained trained assistants, fortunately, to meet this demand. But I'm hearing stories like this throughout the pharmacy community, and I do commend them on really stepping up and being able to meet that demand. And because of that, we experienced a bit of a shortage from public health. Literally, we actually cleared the depot within 2 months. So that's another challenge. Even though we were able to be out there and vaccinate, there's a lot of frustrations because unfortunately of the flu vaccine, public health may have not budgeted adequate vaccine to meet this year's challenge. As I know as a pharmacist, there is a lot of vaccine hesitancy. I've done research in this area. But this year, it seems like patients are more aware that vaccines are more and more important, especially in the age of COVID. And the news stories, headlines, and all that are real. So this is an actual picture. I'm already rolling into work. I was actually able to, my camera lens wasn't wide enough to capture the full line actually. So this is just an idea of what we're facing on a daily basis, and also being able to vaccinations patients safely, making sure they're properly socially distanced, rigorous sanitization on a religious time clock. But the challenges are real, and some of the concerns that my staff have brought up is how are we protecting them, and also public fear of exposure to get their vaccines in such a crowded place. So these are always questions where it's a evolving conversation and management challenge on a daily basis. But with our experience, we were able to adapt, and the public do see that we do everything we can within the resources and space that's allocated. And oftentimes we do get personal thanks and props, which really makes my day well worth it as a new dad as well. Going home to the family, that's always the back of my mind, like what am I carrying? So I make sure I follow a strict protocol, a full strip of all my clothes when I go home, shower. So it is hard. I can say that, and I can speak what a lot of pharmacists are going through. But it's rewarding, and having a strong team really matters at the end of the day to meet on this demand and public health mandate. So this is how I look like when I give my vaccines. We do adhere to public health protocol, just like the hospitals, surgical mask, level 1 certified, face shield, and gloves. And it unfortunately, with a high demand, we're actually taking twice as long to vaccinate each person. As you can see highlighted, the red text are all the extra steps you have to take to do vaccination safely. So normally I would say pre-pandemic, it takes maybe 2-3 minutes to get a vaccine done, register, go in, pull up their sleeve, vaccinate, done, right? And then they wait for 10 minutes. But in the age of pandemic, we have to deal with technology, servers crashing. So we actually created a digital platform where people can scan a QR code, register, and consent online. But because of the overwhelming demand, our servers were crashing a lot of days, and there was like a lot of frustration with that. But what we survived, we got through it, and that was something we're quite proud of. And also sanitation is another thing. So a lot of resources, costs on that too, to make sure everyone is vaccinated safely. And in terms of the vaccination uptake, we weren't surprised. So my team and I do take a quantitative practice-based approach. I mean, we do engage in the community, provide services that's demanded of us, but we actually track all that data and publish it to see really what kind of impact can we make, and set this as an example, hopefully inspire more pharmacists to take on this role. And in 2014, we actually surveyed 2,500 patients roughly, and 2/3 of them responded to our survey. You can see a nice distribution in terms of gender and age. And we were actually able to vaccinate 50% of high-risk populations, which is pretty important because I know public health do want at least 80% of those high-risk patients vaccinated each year. And in our pharmacy, at least 50% of those people come to us as their destination of choice to receive their vaccine, which we're quite proud of. There are a couple of questions in the survey, and two of them really highlights what we mean to them as a service, as clinicians to receive their vaccines. So we propose, ask them, were you satisfied with the pharmacist services and injection technique? And you can see overwhelmingly 100% of them were satisfied, with 92 being extremely satisfied. But the game changer here is that was even surprised us a little bit. We also asked them, would you have gotten your flu shot this year if pharmacy wasn't an option? So if pharmacists were never, we're not giving the authority to give vaccines, would you have gone to your doctor or the hospital to get your flu shot? And actually 25%, 27% said no. So you can see the vaccine hesitancy is still very real, still there. This is back in 2014, though. You have to keep in mind probably that there's a lot less hesitancy. But you can see we were able to tap into at least a quarter of those vaccine hesitant patients because, number one, we're accessible. A lot of patients may be doing their grocery shopping, picking up their prescriptions, say, oh, you do vaccines. Sure, why not? Rather than actually making the conscious effort of making an appointment and waiting in the office, all of them would never bother. And we're very highly educated, well-resourced professionals that can often demystify and provide information that they wouldn't have seeked out otherwise. And we've had many of these conversations, and they've been able to convert these vaccine critics to get vaccines, and seeing them come back every year. So Dr. Bridle mentioned a couple of the studies, and it was a bit of an opener. As healthcare professionals, we do go with the journal as our primary resource. But again, I'll definitely check out the concern about the efficacy. So to my understanding from the New England Journal of Medicine publication on the Pfizer-BioNTech vaccine with their phase 3 trial that began end of July, there were 43,000 patients who were enrolled. Which is very significant. So I know there's the concern of this vaccine was approved too quickly, but at the same time, you have to think most vaccine trials only have about 5,000 patients. If you combine Pfizer and BioNTech with Moderna's population, it's easily more than 10 times of the sample. And most of the side effects do occur within 6 weeks post immunization. And within that 6 weeks, the vaccine would have been degraded and eliminated from the body. So most of the acute and significant side effects would have shown during this trial. So as a clinician sort of evaluating this primary literature, I would get it myself for sure. It does seem safe, but Dr. Bridle does bring some concerns about efficacy. That is very interesting to me because there's some data that may not be fully disclosed. But to the proposed 95% efficacy, that is amazing if that is true. And how they did it was they completed the 2-shot series, and the first 170 confirmed COVID cases, they unblinded the participants, and only 8 of those who were vaccinated failed. So they only had a 5% fail rate from how I interpret the study. But we have that's to be questioned in terms of further development. Unfortunately, this vaccine has to be frozen. That's something we won't probably be doing in the pharmacy. With the Moderna, it's a bit more forgiving. It's stored at -20, but once you thaw it, you have 30 days to use it up. So that's something that pharmacies would probably provide. And in terms of the questions I get from patients is the special populations at McKesson Specialty Prescription Services. I do deal with cancer patients who are on also chemotherapy, people with autoimmune disease, and I also often get asked, can I get the vaccine? So that's an evolving question. you have to evaluate the risk versus benefits, their likelihood of catching COVID, the consequences of doing so, and really what's the danger of getting the vaccine. And most of my patients, I do tell them the benefits greatly outweigh the risk, but it's a more individualized consultation that I will have with each patient. Last but not least, COVID-19 testing. So with one end of the story is flu vaccination, the other one we're doing COVID testing. So it's I don't know sometimes how I managed to make it all happen, but we do. We have great staff, multiple pharmacists, 2-3 pharmacists at a time, an army of technicians, sometimes 6 or 7. It feels like I'm in a war zone sometimes. So that's Philip Kim. I'm a trustee pharmacist. He's at the other store. He does almost 5 COVID tests every minute. So at the busiest time, we had 2,000 people on the waiting list. So we've gotten it down to about 200 right now. But again, these are asymptomatic COVID patients. Shouldn't have any reason for them to be positive. Again, rediverting those unnecessary hospital and physician visits. And that's what pharmacists are about. Thank you for your time.
Thank you, Wilson. That was great. Up next, we have Jean-Paul. Wilson, if you wanted to unshare your screen there. Perfect.
All right, how are we looking?
Looks good.
All right. Okay, so today I'm just going to give a little summary of the state of COVID-19 data as it's being publicly released, as well as just kind of a quantitative perspective on the speed of the rollout in Canada, both an internal domestic comparison as well as a little bit of an international comparison as well. So just a little bit first on the group that I co-founded, the COVID-19 Canada Open Data Working Group. We're drawn from a team of volunteers, mainly from U of T as well as the University of Guelph. And we've released a daily COVID-19 data set since approximately mid-March. And the reason that this group started was we noticed very early on in March that there was really no way to get a kind of one place to get a pan-Canadian perspective on the COVID-19 pandemic. There was an article in Maclean's that had the subtitle, inexplicably, the federal government is not publishing national infection numbers in a way that allows us to see the much discussed curve in terms of flattening the curve. And I think this was about 2 days before we actually published our data set publicly alongside our data dashboard for the public as well. And so we knew we were on the right track there. Pretty much the same story with vaccine data. So ever since V-Day, which was December 14th, when Quebec and Ontario administered the first non-clinical trial vaccines in Canada, we've been tracking this COVID-19 vaccine data, which includes both doses administered as well as doses distributed at the provincial level. And very soon we'll also include the number of people fully vaccinated. So both of the vaccines currently approved, of course, need 2 doses to achieve full efficacy. So in terms of the state of COVID-19 data, it's been getting better over time. At the moment, all provinces provide at least weekly updates, in many cases daily updates on the number of doses that they've administered. They've been moving towards providing this regularly on their provincial websites, but in some cases we still have to look for things like press conferences and stuff like that. Certainly early on, we were watching a lot of press conferences and basically just waiting for journalists to ask about the number of doses and reporting that. But as I said, it's gotten better over time. But in terms of one place to get a pan-Canadian picture on the number of doses that have been administered, at this point, you still have to go to an unofficial tracker, such as the one that we run, or there's a couple others as well. In terms of vaccine distribution, the federal government, as of a couple of weeks ago, is now providing a pan-Canadian picture on the number of doses distributed. That's updated weekly, so sometimes you can get more recent numbers from the provinces individually. And at this point, only some provinces are providing numbers on the number of people that are fully vaccinated, so the ones that have received both doses. So there's been a conversation recently about the so-called vaccine gap, which is the difference between the number of doses distributed in each province and the number of doses that have actually been administered. So in a more pithy sense, this is the difference between vaccines in freezers versus vaccines in arms. And one of the reasons that this has been part of this conversation, and one of the reasons why this data that we and other groups are providing is because without all these numbers on the number of vaccines released and the number of vaccines actually administered in one place, it makes it much harder to see this vaccine gap between doses in arms and doses in freezers. So here you can see, based on data up to yesterday, the vaccine gap in Canada. So here in gray, we have the number of doses that have actually been administered, and in blue, the number of doses that have been distributed. So you can see that the vaccine gap is shrinking as the rollout is speeding up, but certainly we haven't quite gotten there yet. And this is also quite a complicated picture if we actually break it down by province. There's quite a lot of differences. So this shows the percentage of vaccines distributed by province. It's actually not quite accurate in terms of some provinces. We have more recent numbers on administration than on the number of doses that have been distributed. And so some of them, I think we'll be getting updated numbers on distribution today, but it appears that they've distributed basically all that they've received. But presumably they've received a couple more. We just haven't gotten those updated numbers yet. But you know, if you're at a place where you're only a couple days away from distributing everything, then you can more or less say that you're distributing them as fast as you can actually receive them, which is good. And we see that a couple provinces are in that category. Alberta and BC, for example, are pretty much giving them out as fast as they can get them within a couple of days, whereas some other provinces are significantly behind. Some other things that can cause a difference here is that some provinces are only updating, once a week or so. So that kind of distorts the picture somewhat. But also there's differences in the strategy for vaccine distribution. So for example, early on, there was a recommendation that that the provinces hold second doses in reserve. The thinking on that has changed, and most provinces have since moved away from that strategy, basically trusting the supply chain will transmit those doses in time for people to receive their second doses, as opposed to holding them in reserve. And there's also the question of the timing between doses. So for the Pfizer vaccine, the original trials, they had a 21-day period between the first dose and the second dose. And I believe for Moderna, it was 28 days. Very recently, Health Canada has approved waiting as much as 6 weeks between those first doses and the second doses, under the logic that the partial protection provided by having that first dose out to as many people as possible is worth potentially delaying getting the full efficacy of having both doses. And some places, such as Quebec, such as the UK, are considering extending that window between the first dose and the second dose by even more. So that also complicates the picture of differences in rollout between provinces. So here's the provinces that are currently providing numbers on the total number of people who have been completely vaccinated, so receive both of those doses. You'll see there's quite a stark difference between Atlantic Canada and the rest of the country. A couple provinces we don't have data for yet. Part of that is based on kind of following that idea of holding doses in reserve, although again, I think most provinces are moving away from that, but certainly that has affected how vaccines have been distributed up until now. Here's another way of looking at interprovincial comparisons, looking at the number of doses administered per capita, so adjusted for population. PEI often comes out favorably in these metrics. It happens with testing as well, just the fact that they're so small. means that they usually come up pretty high on these metrics. But you can see that, again, Alberta and BC are kind of leaders here, Quebec as well. Some other provinces are a bit behind. At a Canada-wide level, we see that the speed of the rollout has been accelerating ever since they began in the week of the 14th. Not every province began at the same time, but I think all provinces did begin the week of the 14th, and the territories began later on because they received the Moderna vaccine rather than the Pfizer vaccine, and the Moderna vaccine was approved later. But certainly we've seen a speed up in the rollout. But as mentioned by one of the previous presenters, it's not exactly fast enough just yet. So we're administering about 35,000 doses per day on average at the moment, and we need to administer, again, assuming that we only have 2-dose vaccines. It's possible that a 1-dose vaccine will be approved in the future. And if we target a population immunization level of 80%, again, this assumes that these vaccines will eventually be approved for use in children, which neither the Pfizer nor Moderna vaccine currently is. If we do some really rough back of the envelope math here, we see that at the current pace, vaccination will be complete in late 2025. Now, that being said, once we start to receive vaccines in much greater numbers and roll these vaccines out to the more general population, hopefully beginning in spring, these numbers are going to increase a lot. So expect this calculation to change significantly within the next couple of months, but that kind of gives a perspective of our current speed of rollout. If we do a comparison at the international level, this chart is taken from Our World in Data, but I do feel justified in this as we are providing the Canadian data for them at the moment. We can compare ourselves to the rest of the world and to some of our peer nations. We're certainly ahead of the rest of the world, but of course this is, so if you look at the world average there, but of course we have to take this in the context of, we approve these vaccines relatively early, we received these vaccines relatively early, and certainly we are lagging behind some other countries that have been criticized for the speed of their rollout, namely the United States, United Kingdom, but most especially Israel, which has been really the leader of the world in vaccine rollout. And it's certainly not too soon because it's happening amidst another surge of COVID-19 in that country. They've been in their 3rd lockdown at this point, but they have managed to, I think they're vaccinating somewhere in the order of, I believe it's 150,000 a day or so over the last couple of weeks. And for a country of 9 million, that's a pretty impressive speed, much smaller than our country. But most importantly, this is over 20% of their population at this point has received at least 1 dose, and over 70% of their population over 60 has received at least 1 dose. And this is critical because it means that we'll be significantly reducing severe outcomes in COVID-19 in Israel very, very soon. It's going to have a huge effect. And they say that they may be able to vaccinate everyone by early spring, but this, of course, assumes that they'll be able to keep up the current pace of receiving vaccines so that they don't run out at the pace that they're at. So in conclusion, there is significant variation across provinces in vaccination plans, rollout speed, and the quality and frequency of the info being released. I expect this to get better in the future and eventually for the federal government to have kind of a centralized source of information as they did for cases and deaths, for example. And although Canada is vaccinating them faster than the world average and some European nations, we still have a lot of catching up to do. And finally, it also highlights the importance of open data in the absence of an official source to provide information for all of Canada. Having open data through these various trackers, including my groups, has helped to drive the conversation regarding Canada's vaccine rollout and highlight this gap between how many vaccines that the provinces are receiving and how many they're actually putting into arms. So if you're interested in more in this and getting the raw data or seeing our COVID-19 dashboard, which has some vaccine tracking information right now and will be updated with even more very shortly, then you can feel free to visit our website at opencovid.ca and you can find links to everything there. And that would be the end of my presentation. Thank you.
Thank you, Jean-Paul. That was great. There was some amazing visuals in there. So I'll pass it on to Dr. Mulligan now.
Thanks. Can you see my screen? Great.
And yes.
My name's Kate Mulligan. I work with the Alliance for Healthier Communities in addition to the University of Toronto. And we're an organization representing community health centers and other comprehensive primary healthcare organizations right across the province of Ontario. And I'm going to talk a little bit differently from what you've heard in terms of retrospective analyses of where we are with vaccination, and think ahead a little bit to when we're at wave 2 of the vaccination, when we're starting to look at community vaccination. What are some of the key policy principles and practice principles that we need to be establishing now to make sure that health equity and efficiency are at the forefront? Okay, so I'm just trying to, there we go. There are strong reasons why some communities may mistrust vaccination efforts. There is a long history of racism, for example, in our medical traditions in North America and around the world, from the Indian hospitals that intended to segregate Indigenous people from the mainstream population based on misplaced fears related to public health, to the Tuskegee syphilis experiment in the United States around Black populations. We know that racism continues here, and we have seen this replicated in the data about COVID risks and infection rates for racialized people who are also frontline workers and highly at risk of exposure to the virus. So there are ways, though, that we can help to overcome this earned mistrust and rebuild trust with the communities who really need to have access to the vaccine. And I want to really root this in the capacity that these communities already have, that we're not going to come from a deficit-based understanding that sort of assumes that there's something wrong with populations who are at high risk or have mistrust. In fact, they have quite a lot of capacity to lead this work themselves, given the appropriate structures and resources from partner organizations, from government, and so on. And so these are some examples. These photos are from the Black Creek Community Health Center's mobile testing clinic in Northwest Toronto, where we were able to demonstrate very, very well that these communities can do this work, do trusted outreach with those people at high risk, provide the clinical services that are needed, and provide the wraparound supports that people need also to build that trust, to make sure that people are going to have support to keep their jobs, to maintain housing, and so on. And these are the kinds of principles that can also be applied to our work on the vaccine rollout in wave 2. So the bottom line is that one size does not fit all. We can't have just a single approach when it comes to health promotion and communications, and when it comes to distributing the vaccine, reaching out to populations. So I've sort of summarized this as the 5 C's, principles to keep in mind as we start to develop this work. And this is part of what I bring to the work at the Toronto Board of Health, but also to primary care, which is, family doctors, nurse practitioners, and teams who have the opportunity to meet people where they're at. And so this picture here is of a TTC bus that's been converted into a testing site and could also be used for vaccination, for example. So the principles that are vital here to really keep trust and build trust and maintain trust with communities with reasons to mistrust are to make sure that communications that you do have are clear, trusted, and culturally relevant, that people are involved in co-design, that communities and clients are there right from the beginning in developing your strategies to make sure that it's having its intended effect, that we see better collaboration across silos, across health and social silos, so that we're able to refer people to community services when that's needed, that community agencies, even in the non-health sector, are able to do some of the health promotion education and outreach in many languages and in many ways to reach people where they're at, and then collaborate with health to deliver that vaccination service and help bring people to vaccination, but also collaboration across different parts of our healthcare system. So we have seen many cases over the life of the pandemic where hospitals are seen as the center of health and well-being. But there are many times when community agencies are actually better placed to do some of the work, and when primary care is able to reach people in their homes and in their communities in a way that acute care just doesn't have the capacity or the background to do. We need to have collection of socio-demographic and race-based data and open and transparent reporting about that, so we know that there aren't people who are being left behind. What we have found, again, in the pandemic is that health equity has tended to be an afterthought. It has been something that's been implemented, if at all, after a great deal of advocacy and work behind the scenes by healthcare providers, community and social service organizations, and others right across the province and right across Canada. And so we want to make sure that we're able to kind of upfront some of that work. And one of the best ways to do that is through a contribution of government resources directly to community. So make sure that these community agencies and organizations are funded to lead this work, not just to be part of the work, not just to be directed by local hospitals or acute care about what to do, but to take leadership based on those trusting relationships that they've developed over many, many years with community. So very briefly, I want to tell you about the Ontario's Primary Care COVID-19 Vaccination Advisory Council. And this is an opportunity to bring primary care providers together. And it doesn't happen all that often. Many primary care right across Canada is quite fragmented. There are many different kinds of models. There are many different types of practitioners. And there are many reasons why at times they've been in competition rather than in collaboration. But because the vaccination effort is so vital, they've come together in a very collaborative and effective way as a coalition representing many healthcare providers and many teams, including Indigenous primary healthcare teams, many of whom are also members of our Alliance for Healthier Communities. So some of the principles that this group has brought forward that are important for the rollout of the vaccine are that primary care has a really important role to play. And again, primary care has been, for the most part, an afterthought. It has yet to become a core part of the planning. And part of this is because Wave 1 has very much focused on long-term care, retirement homes, and healthcare workers. And so my expectation is that primary care needs to be, and hopefully will be, included in, better included in the next wave planning. Because PCPs, which means primary care providers, can really lead mass and mobile vaccination clinics, just as we've done for testing, can collaborate with public health and pharmacies, can lead that equitable and locally tailored response that I've mentioned, and can identify the people who really need this most, right across settings. Because primary care providers have relationships with people that are longitudinal. These are people that they've worked with for many years and know well. Primary care providers can also build trusted relationships with those community groups that I mentioned earlier. And this is particularly important in northern and rural communities, in Black and Indigenous communities, but also in faith-based groups and other priority populations where there might be different reasons for vaccine hesitancy. And then primary care providers can also partner with other healthcare workers like emergency services to do that community outreach that's so important to meet the needs of people. Primary care providers are also often well-trained in anti-racism and cultural safety. So they can take that starting point as a way to begin addressing vaccine hesitancy, and can also support science-based communications in their local communities and be a voice for the science behind the vaccine in a way that's accessible, anti-racist, and culturally safe. So what we need in order to be able to really implement this and to make it a reality that primary care has an important role to play in health equity and vaccination is clear communication from government and between service providers, so that we have role clarity about what we're expected to do, who's doing what. And right now we're not there yet, but based on strong collaborations, we are on that journey now. We need culturally relevant public education campaigns that encourage patients to speak with their primary care providers. And that can include pharmacists, it can include many different members of the healthcare team. And then we also have co-designed and targeted campaigns that address what we have know from the evidence and from our experience are common causes of vaccine hesitancy. We need administrative support and a better way to collaborate with public health units, for example, and logistical supports. And again, this is in many ways sort of building the airplane while flying it. That these should have been in place, these partnerships and collaborations across the healthcare system, but they just weren't. And so we're building this as we go. And lastly, we need the resource and the data support that I've mentioned, financial support to do this work, user-friendly ways to track sociodemographic data, and a registry to help avoid work duplication and so on. So I'm going to leave it there, and I hope you'll remember at least one of the 5 C's that are important principles as we move toward community vaccination: communication, co-design, collaboration, collection of sociodemographic and race-based data, and the contribution of resources to community to make it happen. Thanks.
Thank you, Dr. Mulligan. Thank you to all panelists for your insightful presentation. I would now like to open up the floor to any questions from the audience. Seems like we've gotten a lot of questions in the Q&A, so I'll just slowly go over them. The first one for Dr. Bridle: is there a delay in receiving the second dose within a certain time frame? Will people need another dose if there's a delay in receiving the second dose?
Yeah, it's a great question, and again, one that I've been asked, so it's okay. I'm quickly going to bring up my presentation. Can you see it?
Yeah.
Perfect. Because I have a slide here. Let me see. Hold on. Here we go. Yes, related to one of the ones I was predicting. So what are the risks of using COVID-19 vaccines and ways for which they were not approved? So indeed, as was mentioned, because of the logistical challenges, there have been talks not only about altering the intervals, but in some countries also talking about potentially combining vaccines from the different manufacturers, and or just administering a single vaccine, right? So you get more people vaccinated. Now, I can't emphasize enough, these vaccines, the only use for which these vaccines were approved, like this is just, I mean, this is law for a regulatory agency, right? When they approve a vaccine, it is based on the way it was used in the phase 3 clinical trial and with 0 deviations. So, I mean, so basically what it means is so that, you know, the efficacy data, right, the effectiveness data that was reported, the safety data, all of that hinges on the vaccines being used and the way in which they were tested. If you deviate substantially in any way, either in the dosage or the interval, and certainly if you mix different vaccines from different companies, there's no guarantee at that point about the performance or safety of these vaccines. So I just want to point that out. The FDA has been very clear on this. They've been very concerned about seeing this. So that, I mean, that's the reality. Okay, that's the fact. So I would argue, I mean, not just me, regulatory agencies would argue deviations in protocol should not be tolerated. The only way that you can safely alter the approved protocol is if you go back and you do the experiments for that. And that's often done. So I wouldn't be surprised, right? In the future, I'm sure a lot of these companies will go back and they'll look at different intervals, et cetera. You know, there is talk about companies collaborating and seeing if they can intermix their vaccines and use one manufacturer's followed by another one. But until that's done, so in other words, there would have to be a repeat of the phase 3 trials using those new protocols. And one of the concerns that I have with these very long, if we lengthen these intervals, so there was one question I saw about whether like a third dose would be needed. That's not necessarily going to help. They're not going to give a third dose. The concern from an immunological perspective is when you give a second dose, your goal is to boost the immune system. And what you're doing, the first dose primes the immune system. It's usually a relatively low magnitude response, and then that disappears. And if the vaccine has worked well, you're left with what we call immunological memory. And it's those memory cells that you want to target with your second dose, because then they expand super rapidly and to incredibly high numbers. We call that a secondary immune response. So that's with these 2-dose regimens, that's when you really get your protection. Now, the problem is this: if your if the immune response induced by the first dose is quite weak, the immunological memory that's conferred is going to be quite weak and could wane. And so this is the problem. So if you lengthen the interval too much, and you actually have had such a weak memory response that is gone by the time you give that second dose is functioning like the first dose, and you're not getting that protection. So leave it at that. But I as an immunologist, I am flabbergasted that there would be any consideration given to changing these vaccine regimens in any way.
Thank you, Dr. Bridle. To follow up with that, this is more of a personal question, but for Canada rolling out their vaccines, have they been rolling out the second dose within that 1 to 2 week time frame? I'm not sure if any of the panelists can speak to that.
Yeah, what I can say is, so when it comes to that, this is where it's challenging. So what we have seen in Canada is decisions, and it's based on each province and territory is making its own decisions in the rollout. But what common practice right now is to use all of the doses as they receive them, and to not reserve doses for the follow-up vaccination. So again, if you want to ensure that the interval is appropriate, like is the correct interval, what you would do is when public health unit receives those vaccine doses, or pharmacy, whoever receives them, you would divide them into 2. You would set half them aside, and then you would vaccinate the people with half those doses. That way you can be absolutely certain that you have the doses waiting for them when they come back. What has been happening is to try and get as many people, to confer some level of immunity to as many people as possible. Is what's more often happening is they're using up all the doses they received, with the expectation that they are going to get a sufficient number of second doses delivered in time to meet that interval. But so you can imagine, so there's risk there. So, I mean, if the vaccine manufacturers fail to follow through in a timely fashion with those second doses, or can't manufacture enough to get all those second doses done, then inherently there's going to be deviations from the protocol.
Okay. Thank you. This is a question for Wilson. Is the data on the number of vaccines administered by pharmacists available by province?
Oh, thank you for that question. So I do practice in Ontario, and most of my data is from Ontario. I'm sure it is available. I just don't know off the top of my head. But much more relevant question, let me, I'm not sure you remember from one of my earlier slides, is more of a pertinent question would be, are all pharmacists vaccinating across Canada? And the question is actually, sadly, no. Because actually some provinces, pharmacists still cannot do vaccinations to this day, which is a bit surprising. One of which is Quebec, them being with their numbers going up just as bad as us. Pharmacists are not engaged in even simple flu vaccinations, which I'm a bit dumbfounded. Because of that, the pandemic, there is a lot of advocacy from the college, and that right is pending. So I would imagine them to participate, hopefully, in the COVID vaccine rollout soon. Mm-hmm. So that's something I'm more looking forward to. And other provinces that have not gotten rights would be Northwest Territory and Nunavut. So those haven't had any talks, which is again a shame. And especially with the high risk patient population there, the accessibility to healthcare. providers. So if pharmacists are able to do it, I think it'll help that population as well.
Okay. Thank you for providing that answer. I was actually going to follow up with asking about the delivery of COVID-19 vaccines in Canada by pharmacists and whether it's been approved or their kind of vaccination plan.
Yeah. So it's related to the scope of giving flu vaccines. So if we can give flu vaccines, we can give COVID most likely. So the college is still working with that because it is a restricted scope. But my understanding today is like if pharmacists can do flu vaccines, we can do COVID vaccines as well.
Okay, thank you.
And just to add quickly, from a data perspective, I'm sure these data exist somewhere, but as far as being publicly available, I have not seen anything like that.
Mm-hmm. The next question is actually for Jean-Paul. Is there a dashboard that publishes the vaccination data?
Yeah, so there's a number of dashboards. One would be our dashboard does that. We also have the raw data available. There's the COVID-19 tracker.ca as well. Another group, I think CTV has one, and I think CBC might be running one as well. So, for us, you can visit opencovid.ca and you can find a link to our tracker there, but you can also look for the aforementioned ones. And I can say from our perspective, if you look at all the plots I showed you today, those are basically prototypes for what I'll be adding to our dashboard soon. So, yep, you can track it from a variety of sources. But as of yet, there's no centralized official federal government source for administration, at least.
Thank you. I don't know if you can speak to this or if another panelist would like to, but another question is, given the new information that Pfizer is modifying their European production lines and shipments of vaccines will be delayed, are there concerns for provinces that have not reserved doses? If I read it too fast, please let me know.
Yeah, this is Byron speaking. Again, this comes back to the issue of the intervals. Clearly comes back to that. And again, that's the big risk that's being taken. If all the doses that are administered, again, this raises a great point that links exactly to this concern that I had with all these doses being administered up front. It is just this. There's no way to predict if there's going to be any problems, right? For example, at any time there could be a quality control issue with a batch of the vaccine. If that happens, that batch isn't going to go out, and there's going to be all kinds of places who are waiting for that order. So it is a big risk. Again, I saw, so I could tie this into another question that was here that again related. Then why did Quebec? Why are they looking at extending the interval to 12 weeks? Well, this is why. It buys them more time to try and find it. So it's coming down to logistical issues, not sort of the rules that govern vaccinations. I've been amazed at how few immunologists seem to be listened to in this scenario. Again, and you don't have to listen to any immunologists. I would just point everybody to the FDA, a very well trusted regulatory agency, and they are saying, please, everywhere around the world, use these things as they were approved, right? It's just like any drug. Like you can't use the drug unless it's special permission, right? And usually like as an experimental, in rare experimental cases, but otherwise off-label use of any medication it could result in unexpected outcomes, right? The only way we can expect these things to perform the way we've been told they should perform is if we use them the way they were used when that performance data was generated. I just can't emphasize that enough. And any regulatory, any health regulator would want me to do so.
Thank you.
If I can just add something, just from an epidemiological perspective, I think there's also a risk of holding doses back and denying half of the population potentially from the benefits of partial immunity, if we are relatively confident in the supply chain that we can get, the majority of people on whatever schedule has been chosen. Those vaccines sitting in freezers, if we do in fact have a vaccine supply chain that's sufficiently secure, has no talismanic effect on the virus. And so I think there's also a risk of holding those doses needlessly and denying people the benefit of partial protection.
Thank you. This question is for Dr. Mulligan. Do you know if there are any advocacy groups who are advocating for essential workers to be considered as a priority group for vaccine rollout?
Yes, I would consider the Alliance to be among them. And this will also be coming to the Toronto Board of Health on Monday, the 18th, where we'll be trying to call for more openness in terms of the prioritization plan from the province of Ontario, so that we can get a better idea of exactly who will be prioritized for that community rollout. And certainly essential workers, in our view, should be high on that list.
There's one more question for Dr. Mulligan. This is a bit of a long one, but I hope you can keep up. Regarding the rollout for fixed and mobile vaccination clinics, Toronto Public Health is about to launch a proof of concept vaccinations clinic for a 6-week experiment, providing 250 vaccinations per day for City of Toronto employees who work in shelters, streets to homes outreach, and harm reduction workers. A report will be given to MOH regarding logistics, IT, patient flow, HR, etc. Why is this needed when public health units have been engaged in influenza vaccination clinics for years? Why is there a timid bureaucratic response instead of an urgent public health emergency response?
I can't speak to all the details of that particular clinic, but certainly I think in principle that primary care providers and public health providers would agree that there are longstanding practices and expertise that have not yet been tapped, and that really should be. And so this is something that will also be going to the board on Monday, and that's an opportunity for you to raise those questions directly as well.
I'm going to now ask a general question. Anyone is free to answer. I'm curious to get the panelists' perspectives on how they think vaccination rollout progression impacts general population behavior, for instance, adherence to public health guidelines, and when we might expect to see the effect of vaccines/immunity on the daily case counts in Ontario and Canada broadly.
I guess I can give a kind of an epidemiology public health perspective on this. I think we should not, present this as if, oh, the vaccine's here, therefore we don't have to worry about things. Obviously, in many ways, we're entering the most difficult phase of the pandemic this winter. Certainly, the weather is not working for us at the moment. But on the other hand, I do think it's important to present this as kind of a ray of hope, a positive number to follow, and also kind of almost fulfilling the bargain that we've made with the population, which we've asked people to make these huge sacrifices throughout the pandemic. Say, oh, Christmas is different this year, but next year it'll be better. And I think this vaccine rollout, being as speedy and as efficient and as equitable as possible, is kind of fulfilling that bargain. From an epidemiological perspective, certainly, the first wave of this vaccine rollout will have a disproportionate effect on deaths, especially in the long-term care setting. But in terms of actual cases, in terms of transmission, I mean, by spring, we're still going to have a very small percentage of the population vaccinated. Of course, when we go into the spring, the weather will be working for us rather than against us. But in terms of the vaccine directly having a large effect on transmission at that point, I don't think that's going to happen until we have kind of a more widespread rollout beginning in the spring. But certainly it'll have a disproportionate effect on deaths if we manage to roll out quickly in the long-term care setting.
I can add to that.
I can add a point.
Go ahead.
Oh, okay. Thanks. Yeah, I can add a point that relates to another question that I saw as well. Remember that when these vaccines are being distributed, so one of these questions was, are the goal of these vaccines to protect from infection or to prevent disease? And again, it was established that vaccines would be approved for use if they were 50% effective, and it didn't have to be 50% effective at preventing infection, but rather preventing disease. Because again, the goal initially is if we can reduce the deaths and or the number of severe cases of disease, that's a very useful application of the vaccine. So this is important to keep in mind, because the ultimate goal of a vaccine is to confer what we call sterilizing immunity, which means that you get rid of the virus from the body. And that means that person cannot pass the virus on to somebody else, right? We don't know with these vaccines. They haven't been tested sufficiently to know if they can achieve sterilizing immunity. And that's just it. They may just blunt the disease. If that's the case, people will still, we could in essence be creating asymptomatic carriers, right? They don't get sick or they don't get severely sick, but the virus can replicate to some level and they have the potential to spread this. If that's the case, it could be a while. And what I want to point out is remember, that's exactly why, because we don't know, that's why everybody who's getting vaccinated cannot deviate from the protocols the rest of us are to follow, right? They still have to wear masks. They still have to do the physical distancing. So on that basis, it may actually look like, I expect that we'll see a drop in, over time in the case rate. But we have to keep in mind that, once we reach some point where the government's comfortable saying, okay, now we can start approaching, normalcy again. If those vaccines have not conferred sterilizing immunity, and then all of a sudden people go back and are interacting, I expect we'll see a flare up again in the cases, right? So it's very hard to predict, because really a key piece of information, again, that's missing is just how good these vaccines are at preventing spread from person to person.
Just to add from the public policy perspective, what we've really seen so far in Ontario in particular throughout the pandemic is that population behavior is more impacted by the provision of supports to follow through on public health measures than it is by any of the numbers. So even though we're seeing, rapid rises in case rates, my daughter's here with me, we are seeing rapid rises in case rates, but we're also seeing more people not following public health measures, even in this time where there's been a declared emergency. And part of that is because we don't have paid sick days. We don't have supports to help people maintain their housing, and we don't have any kind of meaningful and equitable enforcement when it comes to public health measures. So those have been more significant. So I don't know that we will see, my kids are ready for bed. I don't know that we will see, a significant shift. We will need to make sure that those supports are in place so that we can make that happen. And hello from my 6-year-old.
Thank you.
Yeah, and from the frontline healthcare perspective, because I do see these people on a daily basis, I do see vaccine hesitancy dropping quite a bit. We're having productive conversations with a lot of first timers, never ever in their life gotten a flu shot before, now asking about the COVID vaccine. So I would say it's overall positive in the medical community with vaccinations. That's always a struggle in getting the vaccination uptake up. I know that's one of the goals of public health to increase uptake. But through the pandemic, I think we're having a lot of constructive conversations with patients in the pharmacy.
Thank you, Wilson. I think that was the last question we can take for today, since we've passed our 7:30 mark. On behalf of the Infectious Disease Working Group, I'd like to thank Dr. Bridle, Wilson, Jean-Paul, and Dr. Mulligan for their time and discussion today. You've provided invaluable information in a time when there's a lot of uncertainty. Thank you also to our audience members for your participation. We hope you continue to engage in this important topic and find ways to share the things you've learned today. Stay connected by following our social media and by following our panelists and their organizations. Thank you again to everyone for joining today. Stay safe, stay healthy, and stay informed. We hope to see you at our next event.
Hey, Kira, just before you dismiss everybody, could I just say quickly one thing? Like a bit of a good news part here, because we've talked a lot about issues.
Yes.
So I just want to point out, because we are relying a lot, we put a lot of reliance on these vaccines, but I do want to point out, so if I have also been asked, if vaccines don't solve the problem in a relatively quick fashion, right? If some of these issues cause problems, it is is there any other way to achieve herd immunity? And it goes back, I can't emphasize enough either, and this was one of the questions, yes, or at least probably, and that's through natural acquisition of immunity, right? So if we all think back to the beginning, remember governments around the world had large debates about do they allow the virus to spread rapidly through their population to achieve herd immunity and preserve their economies, you know, et cetera, or do they lock down and slow this all down a lot, right? So that the hospitals don't get overwhelmed and so on. And we know what route we took here. So the reality is, right, we were all hoping this was gonna be over a long time ago. So now we are more than a year into this, and the reality is we have, a lot of people have acquired natural immunity, right? There's lots of people who have been sick, or no, infected, but never got sick, right? And what I want to point out is we've actually been very poor in Canada at doing antibody testing. So we have no idea how close or how far we are to have naturally acquired herd immunity. But what I do want to mention is, although the spotlight has been put on the very few cases worldwide where there's evidence of reinfection, the vast majority of people don't get reinfected. And there's also evidence of people who have been previously infected with common cold coronaviruses or the previous SARS coronavirus actually have cross protection against this virus. So the good news is the higher that number is, the closer we are to herd immunity, and the fewer people we actually have to either vaccinate or have, or we could get away with less efficacious vaccines. I do want to point that out, but we really need to get a gauge here in Canada. We need to start doing a lot more antibody testing to find out how close are we, right? Already. So those are people who are already protected. And I would also say that then what we should be doing is, if we're being wise with our vaccines, we should be doing the antibody testing ahead of time. Why would we vaccinate people who already have at least some level of immunity? And why wouldn't we be then directing those doses to the people who have none? That's going to get us to herd immunity much faster. So I just want to end with that with a good news note. We might already be some way on our way towards herd immunity.
Thank you, Dr. Bridle. That was really insightful. But yeah, thank you so much.
And everyone will receive access to this recording as well. Thank you everyone for attending. Have a great night.
Bye-bye. Bye-bye.
Bye-bye.
Bye.
Take care, everybody. Thanks for having us.
Have a great night. Thank you.
You guys want to stop the webinar and the recording